Tonight's presentation is titled Peri-Implantitis, How to Merge CBCT with Intraoral Scans to Guide Diagnosis and Treatment. I want to welcome you all this evening. My name is Shirley, and I will be your moderator tonight. I am excited to welcome Dr. Daniel Berant as our speaker this evening. Dr. Daniel Berant, who is, as you can see, sharing his screen right now, is a diplomat of both the American Board of Orthodontists and the American Board of Periodontology. He earned his Doctor of Dental Medicine degree from the University of British Columbia and an array of awards for clinical excellence before establishing his private practice in New York City. And we went through some of these housekeeping notes, but I'm going to take a moment to go over them again. If you have a question, please type it into the Q&A box during the presentation. We will get to them live at the end. And CE is not available for the webinar this evening. With that, Dr. Berant, welcome, and thank you for being with us tonight. I'm going to pass it over to you now.
Thank you so much, everybody. What an honor it is to be here with you on this Tuesday. I'm coming live from New York City. So for all of those joining from around the world, US, Canada, it is a pleasure for me to be presenting on a topic that, frankly, if I may put some music here, peri-implantitis is something that is very easy. As anyone knows, it's very easy to diagnose and it's very easy to treat. Now, as you can see, Pinocchio is responding to everything that I'm saying. And I'm going to be doing all of this in 45 minutes. And the reason I have this song on is because sometimes when we're dealing with these cases, it really feels like you're wishing upon a star to get you the success. And so in reality, what we're going to be talking about tonight is not the fact that it's easy to diagnose, treat, and cover in 45 minutes, but I'm going to do my best to help us understand the basic principles of implantology and how to reduce the chances of complications, and so we can appreciate the factors that we can use to our advantage for implant success. And finally, and most importantly tonight, we'll be talking about how technology, both CBCTs and intraoral scans, can help ensure success. And so when you wish upon a star, you can save your wishes for something more than implants in your patients. So as I was introduced, I'm a double board certified specialist in both periodontics and orthodontics. And for those of you who know the world of perio, we love our classifications. And relatively recently, in 2017, the European and the American Academy of Periodontology came together and formed this world workshop. If you scan that QR code, it'll take you to the main page where you're able to have access to all the papers that they publish that is available to all of us professionals and patients. And so in this workshop, they had a special, the last section was the peri-implant diseases and conditions. And within that, they broke it down into 4 different categories. So the first category is peri-implant health. And again, if you scan that, it'll take you directly to the article, which you can use at a later time. If you want to scan it, just take your cell phone up to the camera, and then that should open for you. Then we're going to talk a little bit about what is peri-implant mucositis before delving into peri-implantitis. Now, the 4th category, which unfortunately we won't be talking too much about, is the soft and hard tissue deficiencies around implants. In the World Workshop main site, you can see the consensus report where they summarize all of these 4 topics and help us how to diagnose and recommendations of treatment planning. So first things first, what is a healthy implant? Well, for a healthy implant, what we want to take a look at is we want to see no bleeding on probing, no signs or indications of radiographic bone loss. Now, the important thing, when it comes to probing depth, they do emphasize that there is no acceptable or range of probing depth. The big thing is the absence of bleeding on probing. And so that leads us to our next point, or our next category, which is peri-implant mucositis. Now, when we're looking at an implant that is suffering from peri-implant mucositis, what you see is inflammation and bleeding on probing. This is almost always caused by plaque. And the important thing is to note is that once the plaque is removed, this condition now becomes reversible. And if you want, there's the peri-implant mucositis position paper located at the bottom left-hand of your screen. The one thing that is really tough with webinars is I have no audience interaction. So if you guys have questions or anything like that, you just let me know, pop it in the chart, and Shirley will help notify me. Finally, and the topic at hand today is peri-implantitis. When it comes to peri-implantitis, there are some cases where it's very obvious, as seen as in this photo, which was referred to me by a dentist. It's usually plaque associated. Starts off, we suspect, from peri-implant mucositis, which progresses. So the inflammation continues around the peri-implant mucosa. We start seeing radiographic evidence of bone loss. And the really big thing, unlike most periodontal disease around teeth, the progression is nonlinear and accelerates very quickly. So we're going to talk a little bit now about soft tissue and hard tissue deficiencies prior to implant placement, things for us to consider. And so when we look at our patients, we have to think to ourselves, well, how did they get here to this position? So when they lose teeth, did they lose it from periodontal disease? Was there a trauma, as in this case? And also, are there systemic diseases that need to be taken into consideration? When we look at the hard tissue deficiencies prior to implant placement, similar to the soft tissue, we think about how the tooth was extracted or how it was lost. Was it lost from periodontal disease, which would indicate there was probably quite a lot of supporting structure, bone loss? Was it trauma from an extraction or an accident? Does the patient suffer from periodontitis? Was there an endodontic infection? Things like longitudinal root fractures can cause areas where there is a lack of bone. And then we talk about anatomical factors. Well, how far is it in the mandible from the nerve? And in the maxilla, is there a pneumatized sinus? All of these things have to be taken into consideration prior to us placing an implant. Now, something that might be overlooked is the systemic diseases. And in addition to that is the social factors such as smoking and different medications that the patient may be taking. Well, what about the soft tissue deficiencies that can occur after implant placement? Sometimes we hope to get lucky and place an implant in an area where there's just enough bone for us to engage the implant and achieve primary stability. There's countless of articles that demonstrate the lack of buccal bone that occurs over time, and especially in the maxilla, where the bone is very thin to begin with. Furthermore, the papilla height, which is determined both by the crest between the implants and also by the teeth next to the area. Something that I see often gets overlooked is the amount of keratized tissue that surrounds our implant. And finally, when it comes to periodontal disease, or I should say, the migration of teeth over time and lifelong skeletal changes, which we're seeing more and more as our implants are lasting longer, that our skeleton continues to grow, continues to change over time. And it's not like what we used to think, that after the growth spurt around 14, 16 years, our bone stays stable. So what about the hard tissue deficiencies after implant placement? Well, there's defects in healthy situations. There's things like the mandibular undercuts, there's fenestrations that occur. And as well, we have to think about how the implants were placed. Were they positioned inside the alveolar housing? Did the patient ever experience any peri-implantitis that caused them to lose bone? Also, we could talk about the crown to root ratio of implants and how the soft tissue thickness impacts our long-term success. And as always, systemic diseases have to be taken into consideration. So what I want to focus on now are things that we'll be using when we look at the cases that are following. What are some of the factors that we look for implant success? First and foremost, we look at the bone and the quality of the bone. Surgical technique, is there plenty of irrigation? How much torque are we placing on our implants when we're engaging? Did we choose an adequate length and width of each implant given the location? And then things that we know, smoking in our patients, the amount of plaque and plaque control, how well our patients are able to control their oral hygiene. And then also occlusion. Non-axial forces, cantilevers, and lateral excursive movements can be detrimental to our implants. Furthermore, the lack of keratinized and attached gingiva, and again, the anatomy and the surface anatomy of the location of the implant, where it is next to the mental nerve, inferior alveolar nerve, the sinus location, and also the lingual concavity. And then finally, other factors that can be taken into consideration is what implant system are we using? What is the surface texture? And what is the process and recommended drilling protocols? And so how can we use technology, both with the CBCT and our intraoral scanners, when we come across cases of implants that we've placed or that are referred to us in trying to create predictable outcomes for our patient? When we look at the next two cases, I want us to think about these 5 things. 1, when we're looking at an implant that is presenting with peri-implantitis, is there any mobility? If there is mobility, the implant is hopeless and must be removed, and we have to start from the beginning. Secondly, is there any radiographic evidence of any radiolucency? To this, I would add, do we have any history of the implant when it was first placed and x-rays that could guide us in regards to the progression of this disease? When we look at bone loss, we can expect vertical bone loss less than 0.2 millimeters annually after the first year of placement. So after the first year of placement, we can have up to 1 to 2 millimeters of bone loss. And after that, we shouldn't see more than 0.2 millimeters of bone loss on our subsequent x-rays. The other thing we want to think about is the absence of bleeding on probing. In essence, the absence of any persistent or irreversible signs and the presence of healthy hard and soft tissue. Now, I put a star along the bottom is the fact that the patient and the clinician secondarily have to be satisfied with the implant in order for it to be truly a successful implant. And so since our time together is relatively limited, I'm going to start off with this first case. This first case is of a 35-year-old male who presented to my office, was referred to me by the general dentist because this implant was causing this patient pain and it was bleeding on probing, and occasionally he would get a funky smell. And so when we take a look at the x-ray, the soft tissue looks relatively okay. However, where do we begin? Well, after we get the medical dental history, we take a PA, which doesn't show any signs of bone loss. But when we take a CBCT, sorry, 1 second. Let me go back to that CBCT. When we go back to the CBCT and start scrolling, I don't know if you can see my mouse, but at the top right corner, we start seeing the lack of bone up to 5 threads on the implant surface. Furthermore, we can note the significant concavity that's located when we're looking at the axial section. As we go up and down the implant, we can begin to see that this implant is in the process of becoming a failure. And so when we talked to the patient, we told him that essentially what we have to do is we have to take a look inside and see if this implant is amenable to grafting. the first thing I did is to check to see if there is any mobility. Unfortunately, there was none. When we raised the flap, we could see clinically the significant concavity that exists for this patient. And so what we do is we begin by cleaning the area, cleaning the surfaces of the teeth next to it. We then begin to prepare for how are we going to replace that which was missing. So in this case, what's missing? Both bone, and we wanted to get some soft tissue augmentation. And so what we did is after cleaning the surface of the implant, irrigating it, we began by measuring how much connective tissue would we need in order to try and augment from a buccolingual or buccopalatal position. So here you can see the soft tissue graft that was harvested. I like to do as a Kelly technique where we harvest a free gingival graft, then we deepithelialize it to get a nice even surface. And here you can see the image of the graft that was used. Then I put in the harvesting site, I use collagen, and then we do periacryl glue. And then on top of that, we provide our patients with a clear surgical stent. For this situation, I used a collagen membrane to help house the bone graft. And here you can see the collagen membrane is tucked into the flap, and we start placing freeze-dried bone allograft bone. And so we plump up the area, we cover it with a connective tissue graft, and then we do our best to secure the connective tissue graft around the implant using 5-0 chromic sutures. And then finally, we take the patient's buccal flap and we try and approximate it to close and cover the connective tissue graft. Here you can see sort of the before and after and the amount of augmentation that we are hoping to obtain. In the buccal view, you can see here the thickness that we're able to get. And then this is how he looks 1 month after. Now, we did lose a little bit of the coverage due to the fact that you can see more of the root surface. However, when we look at the CBCT, this is 2 months after, we see that the bone graft is still present and there's nice thickness to it in an area where previously there was a huge buccal concavity. And so as we go vertically, we gain the appreciation of the bone that has been grafted. And hopefully that will serve our patient and prevent any complications or food getting trapped in there for the duration of that implant's life. And so here you can see the before and after, and then the before and after screenshot. So let's take a look at our next patient. Our next patient is a beautiful 28-year-old female, sorry for the pixelation, that presented to us with a history of a congenitally missing lateral that had an implant placed 3 years ago, and this patient had subsequently seen 3 different surgeons because she wasn't happy with the look of the implant when she smiled and the feeling that she could feel the metal through the tissue. And so this is after the prosthodontist that I work with saw, Dr. Jonathan Levine. What he did is he removed the crown that was there, he put a cover screw, and we tried our best to see how much tissue we would be able to gain just by allowing Mother Nature to take its course. This is after 2 months of leaving the implant in a cover screw and a Maryland bridge. Now, when we look at the CT, what we see is that unfortunately the implant that was used was probably far too large for the area. It was placed too buccally. And on the CBCT, we barely see any bone on the buccal surface. And so after acquiring the CBCT, we also want to acquire an intraoral scan to gain an appreciation of the soft tissue as well as guide us in the provisionalization of this patient. Now, when we look at this screenshot of the CBCT and we take into consideration the patient's presentation, we have to ask ourselves, well, what are our options? Well, option one is to say, oh, you have a low lip line, just learn how to smile without showing it. That's not an ideal option by any means, and one that we would not recommend to any of our patients. Well, the second option, and it would be rightfully justified, is to remove that implant, graft the area, and essentially start new. But maybe there is another option. If we're able to leverage our understanding of biology and take into consideration that there might be some tissue still present that isn't fully visible, maybe we can try have the patient undergo connective tissue and soft tissue grafting to try and plump the area thick enough to compensate for the lack of buccal bone.